Good morning, good afternoon, good evening, wherever you are when you're watching this. This is Howard Goldman from Cleveland, Ohio, Cleveland Clinic, and I'm very happy that you've joined us for this industry theater about macroplastique, tried and true. Dr. Abbas Shoberi, who's from Innova Women's Hospital, will be working on this together with me. And what we'd like to do is really just take you through some of our thoughts and some of the data on why really macroplastique is our injectable of choice at this point. As you can see, I'm from Cleveland, Ohio, and I'm glad you're with us. Okay, why don't we go over some cases, and between Dr. Shoberi and myself, we can sort of see how some real life patients played out. So this is my first case. This is a 57-year-old woman who presented with recurrent stress incontinence after a transobturator sling. She didn't complain of any urgency. She said that her urinary flow was normal. On exam with a cough, she leaked very clearly. Q-tip test was 0 to 20 degrees. Post-void residual was 45 cc's. So one thing that I did do before I was going to go ahead is my practice is anyone that I'm going to do a procedure on, potentially, who's had a prior sling, I usually cysto them myself, just because I'd hate to get involved in something and then find out that there was a sling somewhere that it shouldn't be. So we did do a cystoscopy, which was normal. And in a case like this, personally, I would not do a urodynamics because I think it's pretty straightforward, but certainly some might. Abbas, what are some of the treatment options you would discuss with this patient?
So with this patient, in terms of their treatment, we would do urodynamics on the patient in my practice, but mainly because if it's primary incontinence, we would say we would go by the ACOG criteria that just the demonstration of SUI is enough. But if they have had a prior sling, we would subject them to urodynamics. But after that, if they have had a failed transobturator tape, I really don't think pelvic floor therapy would be much of benefit for them unless on the examination you decide that they really don't have good control of their pelvic floor and they just need a pelvic floor tune-up. But besides that, I think we would either offer them a retropubic synthetic sling, or if the patient doesn't want to have additional surgeries, macroplastic is a great option for her.
Okay, so we did discuss all of those things, really the full, what I call my full spectrum for someone who has failed a prior sling. Typically, though, I would focus in on a bulking agent like macroplastique or doing a retropubic mid-urethral sling. There are some patients who, for whatever reason, have been scared by commercials they see about mesh, or they already had a mesh sling and they failed, and they decide they don't want a mesh sling. But I would certainly, in a case like this, if that was the case, move much quicker to macroplastique, which is much more minimally invasive than going on to an autologous fascial sling. And in fact, this patient did not want any more surgery, and so macroplastique was a really nice option for her. We did one tube. I know it talks about the standard protocol is to often use 2 tubes, so half a tube on one side, half a tube on the other side, and then some on the bottom. In her case, we just did half tube on either side. We had very good bulking, and she was very happy. And on 6-month follow-up, she had minimal leakage, but ultimately was very happy with it. And so we sat tight at that point. Any thoughts, Abbas?
I think that's very much a reasonable option and a great outcome for the patient.